I think I'll save some time for the dinner. It won't be that long. First of all, I'm from Cape Town. I think a lot of you haven't been there, probably. And I think it's time you visit. It's a wonderful place. Yes. We have a water problem at the moment. So we drink a lot of champagne and wine to save water.
Mm-hmm. It's the right time to visit.
Yeah. And we invite our girlfriends over to come and share the shower. We save some water. First of all, I'm going to talk a little bit about the Panoptix IL. As you know, it's also a non-apodized diffractive IL with 88% light transmittance to the retina. It's a hydrophobic 15-step design, effectively giving a 3.25 diopter for near. And it's a trifocal IOL. And it's causing the same photopic phenomena that all the other lenses do, as my colleague Dr. De Lange mentioned. And this is the capsular tension ring that I'm using for these cases. It's traditionally used more for zonular dehiscence or cases like that, Marfan's, exfoliation type cases, complications during surgery. But I believe it can also help with capsular shrinking. And there may be a role in using it more on a permanent basis in premium ILs, and I think I want to address that concept. So I had this case. He was an 83-year-old male. He's a medical professional in Cape Town, and he had an IL placed in his eye, in an only eye. And after 6 weeks, he showed marked astigmatism. And also at 3 months I checked again, and it was still there. So I had to do something about this, because he's for his age very active, plays tennis and swims every day. And I then took him back to theatre, and I found severe capsular contraction and some PCO. It was really excessive. And it was a single piece hydrophobic IL, a C-loop type design lens that he had in. So what I could have done was just loosen the lens and rotated it. Talk a bit louder. So I could have just loosened the lens or replaced it. I chose to replace it with another lens, with the Proline type or PMA type lenses, haptics. And this was just a pentagon. Just you can clearly see there that the lens is tilted from the capsular contraction. And his cornea was normal. There wasn't any corneal astigmatism. So I did the exchange. But over the years, I've done many multifocal lenses. I've been through them all since 1996. And I do see over time, I see changes in refraction. Patients might be in the short term, might be very close to plano with very little astigmatism. And then they come back 3 or 4 years later, and they've got significant SIL, and they're not so independent of spectacles anymore. And if you look at all the studies, just about all the studies are 3 months. I don't think this says much. So I think that one of the reasons is probably capsular contraction or lens tilt over time, as I showed in the previous case. But I think other healing factors may also play a role. Maybe tear film, maybe the tissues might change over time, as our colleague said earlier this morning in the talk, that the sclera might change. And there was this, I came across this study of Klin et al. In the Journal of Cataract and Refractive Surgery, and they looked at refractive changes rather over time, and they found that it was rather due to corneal curvature fluctuations rather than shift in IL position. And they did measurements at 1 month, 3 months, and 1 year. So, unfortunately, again, it's a shortish study. And they only found a 0.03 millimeter shift in IL position. And they found the mean posterior shift 0.033 in a year, and the refractive shift was only 0.25 diopter. They found no correlation between refractive change and IL position in their study. So, I did 52 eyes in 26 patients. 26 were female and 10 were male, and the average was 59 years. And 49 of the eyes were hyperopic eyes. So what I did was, in the same patient, capsular rhexis was 5.25. I used the Varion to get that as close as possible. So the surgery cases were all done by myself. And these were the follow-up dates. Unfortunately, we don't have the long term yet, but the plan is that I keep following these patients over a long time and then see what happens. I put in the dominant eye a capsular tension ring, and the mean predicted aim there was minus 0.20, and the predicted aim range was between 0.14 and minus 0.41. And in the non-dominant eye, I didn't use a capsular tension ring. And the mean predicted aim there was slightly, little bit more myopic. And that's what I try and do in all my multifocal cases, and I think that helps with depth of focus and for near vision. These videos aren't working, but I can show some afterwards. So the uncorrected vision at 3 months post-op with the tension ring was 0.83, and without the tension ring was 0.83. The range was 0.3 to 1 and 0.6 to 1. So not much difference. The uncorrected vision at 40 centimeters at 3 months was very good. It was 0.9. I think that's exceptional. 0.94 without the tension ring. Again, not much difference. Then at 60 centimeters for the intermediate distance, with tension ring 0.53 and without tension ring 0.51. Again, similar, but not as good as a little bit nearer. And then I looked at the post-op spherical equivalent with the tension ring. As you can see there, well, there are very few cases, but at 6 weeks, 6 months, and 12 months, not making a big difference at this point. And this was the eyes without the tension ring. Again, with the tension ring, and then with the tension ring, the mean spherical equivalent minus 0.11, quite good, and then with the without the tension ring 0.31, bearing in mind that that was more or less what we aimed for. And looking at the difference between predicted aim and post-op spherical equivalent. So with the tension ring, mean predicted aim was 0.2 and we got 0.11, so we were quite accurate. Again, as Professor Asya mentioned, we also use multiple formulas and we take a lot of care and we use different methods to measure. And I basically use the Galileo, that's what I use most of the time. Without the tension ring, our predicted aim was minus 0.46 and the mean post spherical equivalence is minus 0.31. So as you can see, the variance was very small, 0.12 and 0.16. With the looking at the YAG capsulotomy, we were doing more because these patients are sensitive to capsular opacity, and sometimes it looks as if that's insignificant, but when you dilate them and you YAG them, then you see, oh well, there's quite a bit of opacity that you don't really see so well at the slit lamp. So I think it's a good idea to YAG them early in any case. We didn't do the lifestyle on these patients because I'm actually looking at this tension ring thing and I want to do a sort of a long-term study on that. So, but certainly the impression that we got is that the patients are not they're not volunteering that they are troubled by Ehlers and Danlos. And it's only when we ask them that they say, oh yes, I mentioned, I did notice it. So it's not that I'm having patients walking in there complaining all the time. So the patient satisfaction is very high with these lenses, and we see that with the referrals. They bring their friends, and they say that, doctor, you're going to be overloaded. We're bringing all our friends. So from our early results is only minimal, if any, difference in target diffraction achieved with or without the capsular tension ring. And we will revisit these cases in a year or two and ascertain whether the capsular tension ring results in increased capsular stability and therefore stable refraction. And as you saw, our YAG capsulotomies were more in the capsular tension ring, but maybe could be less, and we saw that with this innovative capsular tension ring that Hanita lenses have. But it's my feeling that the refraction of the patients are changing over time. There's no doubt about it. And I think, personally, my feeling is that one should be using a capsular tension ring in all multifocal lenses. I do, however, think that the design of the lens also plays a role. Like the fine vision with the should be very stable with the 4, as opposed to a C-loop. I think the C-loop lenses are probably not as stable when you get capsular tension ring in the long term. So, but there aren't a lot of studies out there comparing or talking about this thing over a long time. Most of the studies out there are about Marfan syndrome and other zonular problems and complications in surgery, but not in this type of case. So something like this in the long term will be a good thing to do, I think.